Good day once again. I will be continuing my lecture about anemias and approach in their diagnosis. This is part 4 of my lecture, and my name is Dr. Christian Dominic Rosales. I'm going to start my lecture with a discussion on a condition called as thalassemias. Thalassemia is a group of inherited disorders wherein production of one of the normal polypeptide chains of globin is markedly deficient. Beta thalassemia refers to the underproduction of beta chains. Alpha thalassemia, delta beta, delta, and gamma delta beta thalassemias refers to the reduced formation of the respective polypeptide chains. In mild forms of this disease, often referred to as thalassemia minor, hypochromia and microcytosis are prominent or conspicuous, whereas the anemia is absent or mild. In other thalassemic disorders, particularly the homozygous beta thalassemia, or oftentimes referred to as beta thalassemia major or the Cooley's anemia, as well as the hemoglobin E beta thalassemia, hypochromic microcytic form of anemia is frequently quite severe. They occur primarily in the Mediterranean, African, and Asian persons, and the sequencing of the beta thalassemia genes has revealed more than 100 various causative mutations. The alpha thalassemia are generally due to a gene deletion of various length. This slide shows to you the geographic distribution of common inherited structural hemoglobin variants and their thalassemias. The red cells in this condition are strangely flat with central staining areas and have been called target cells. In beta thalassemia, symptoms occur starting from 6 to 24 months of age, and the severity of the damage depends on the kind of the mutation. In the severe form of the disease, the bone marrow expands as it tries to keep pace with the perceived necessity for new red blood cells, thus setting the stage for moderate to severe skeletal deformities and pain. The principal tool in the recognition is the hemoglobin electrophoresis. In here, the elevated hemoglobin A2 is above 3.5%, as well as an elevated fetal hemoglobin can also be appreciated through hemoglobin electrophoresis. This slide shows to you the crooked appearance demonstrating the bone marrow expansion. This X-ray image can be described as a hair standing on its end. Alpha thalassemias are characterized by a reduction or absence of synthesis of alpha globin chains. Unlike the extremely unstable alpha chains in beta thalassemia, excess beta and gamma chains can form stable tetramers, hemoglobin H or beta 4, and BARTs or gamma 4. Here is a truncated version of the table illustrating the various forms of thalassemia from your trusted Robbins textbook. Now let's proceed to paroxysmal nocturnal hemoglobinuria, or PNH. It is an acquired mutation in the phosphatidylinositol-glycan complementation group A gene, or the PIG-A gene. Cells harboring the PIG-A mutations are deficient in a class of proteins called as the GPI-anchored proteins. The majority of the PNH-related issues will include destruction or hemolysis of red blood cells, blood clots, thus causing thrombosis and infection. In here, it is an enzyme that is essential for the synthesis of certain cell surface proteins. The PNH is closely related to aplastic anemia, and patients have symptoms of acute hemolysis, characterized by often a bright red blood or dark tea in the urine following exposure to cold temperature. The PNH is diagnosed definitively by flow cytometry, which provides a sensitive means for detecting red cells lacking CD59. As a side note, sucrose hemolysis test and Ham test are two clinical laboratory tests commonly done whenever paroxysmal nocturnal hemoglobinuria is considered by the attending physician. Here is a graphic illustration of a flow cytometric analysis. Granulocytes that express neither CD59 nor CD55 make up the PNH clone and are found in the lower left quadrant, meaning around 26% of cells. Normal granulocytes that express both markers are in the right upper quadrant, or around 74% of cells. Now let's proceed to the immunohemolytic anemias, or the AIHA. It is a rare disorder that features red blood cell destruction or hemolysis triggered by a self-recognizing immunoglobulin molecules, or the autoantibodies, directed against endogenous RBC antigens. Immunoglobulin class and optimal thermal binding of the autoantibodies will provide a useful mechanistic description. Warm IHA, or autoimmune hemolytic anemia, and cold agglutinin disease. The diagnosis of immunohemolytic anemia would necessitate the detection of antibodies through the DAT, or direct antiglobulin test, and or complement on red cells from the patient. Warm-type autoantibodies of autoimmune hemolytic anemia are usually IgG antibody, but may also be IgM or IgA, and likely Rh specific. The cold-type antibodies are primarily IgM or IgG, or also called as the Donat-Landsteiner or DL antibody. When the classical signs of hemolytic anemia are absent or difficult to interpret, and particularly when the Coombs test or the DAT test is weakly positive or even negative, the diagnosis of IHA can be challenging and often delayed. Direct Coombs test, or DAT, is described as a test wherein they detect immunoglobulin and or complement molecules on the surface of red blood cells. The indirect Coombs test, or DAT, will entail incubation of normal red blood cells with the patient's serum, searching for unbound red cell antibody in the patient's serum. Here is a table showing to you the causes of secondary autoimmune hemolytic anemia. The type of autoimmune hemolytic anemia is illustrated, and what types of condition occur in the pediatric age group versus those in the adult population. And the causes of the autoimmune hemolytic anemia in each category are listed in order of frequency. The proper treatment of autoimmune hemolytic anemia will depend on the type of autoantibody, the clinical severity, additional or underlying medical conditions, as well as the age of the patient. Corticosteroids are the traditional first line of therapy for patients suffering from warm autoimmune hemolytic anemia. Here is a typical result of a DAT tube test. DAT is positive when there are clumps formed in the tube. DAT is negative when one sees absence of any clumps or agglutination. Let's proceed to microangiopathic hemolytic anemia. This condition is characterized by red blood cell fragments in the peripheral blood, and they're termed as schistocytes. Traumatic intravascular hemolysis arises as a consequence of fibrin strands in the vessel lumens. The macroangiopathic form is observed in persons with cardiac valve prostheses or those of implanted cardiac valve prostheses. Most commonly seen with disseminated intravascular coagulation, but it also happens in thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, malignant hypertension, systemic lupus erythematosus, and even disseminated malignancies. A condition called as March hemoglobinuria arises due to a forceful contact of the body with a hard surface. Hemolytic anemia can also arise as a result of infection, such as in Clostridium sepsis, those who are sick with malaria, termed as black water fever, those who are infected with Bartonella bacilliformis, Babesia microti, parasites such as trypanosomiasis, and a bacteria Mycoplasma pneumonia, wherein the IgM is against the I antigen. That's all for part 4. Please proceed to part 5. Till then, thank you for watching.